Welcome back, everyone. We're going to talk about the couple of disease processes within the gastrointestinal tract now. One of them is going to really highlight some of the really important pieces of physiology. It is referred to as gastroesophageal reflux. Reflux disease. It's so that you don't have to keep saying it. You can just call it GERD. This is the process of acidic gastric contents flowing back into the vulnerable esophageal space. There are different etiologies of this. In general, the major etiology, the one that happens most frequently, is decreased tone of the lower esophageal sphincter. So remember that muscle, that band of muscle that would protect the esophagus from actually getting acidic contents going back. Well, sometimes the tone of that goes down. The tone can go down for a number of reasons. The most common reason why it goes down is advancing age. The older somebody is, the lower the tone of the lower esophageal sphincter. Some medications can decrease the tone as well. And then there are a bunch of foods that can decrease the tone. And I'll list them for you. Mint can do it. Spicy foods, fried foods, or like foods that are high in oils and fats. A high fat content. Acidic foods, like citrus, for example. Caffeine, alcohol, all of these foods, like chocolate. Basically, if it tastes good, it will lower the esophageal, it'll lower the lower esophageal sphincter tone and can lead to reflux. There is the thing that essentially causes everything in medicine, and that is smoking. Smoking cigarettes will lower that lower esophageal sphincter tone. So that's the first thing. That's the most common thing that can happen. There also is there is another cause. Rather than lower the lower esophageal sphincter, you can, if there's an increased pressure in the stomach, it could cause contents to flow back. So increased pressure in stomach. And this could be because of a large meal size. Obesity can do that. Pregnancy. Essentially, when we talk about the idea of GERD, if we look at who gets GERD, up to 20% of the population has it, but 1 in 5. And that's within North America. Most common in people over the age of 40, but really anyone can get it. And men tend to get it more frequently than women. Clinically, this is actually going to present as it'll often, people will feel a burning sensation within their chest. or sometimes in their chest, in their lower abdomen or their upper abdomen, and there's sometimes a burning sensation in their chest. Sometimes it can be really difficult to tell the difference between that and a heart attack. Some people present with symptoms of reflux, meanwhile, they may be having a heart attack. From a clinical perspective, it presents with burning sensation in abdomen and chest. Sometimes people will have reflux that is so bad that they'll get regurgitation of food particles into the back of their throat. If it's particularly bad and it's been going on for some time and there's inflammation in the esophagus, sometimes people have pain with swallowing. This is referred to as dysphagia, abnormal eating or pain with eating. Because there's acidic content, sometimes people will describe a sour taste in their mouth. If the reflux is particularly bad, reflux tends to happen at night when people are laying down in their bed. It will allow for contents to have an easier time refluxing. And if it's bad, it can actually cause there to be the acidic contents can go and cause inflammation of the vocal cords as well. So if there's vocal cord irritation, people will present with a hoarse voice. There'll be some inflammation in the vocal cords, so people will tend to have this chronic dry cough. And it can sometimes lead to inflammation of the vocal cords or laryngitis. And that's if there is vocal cord irritation. Some people have silent reflux to the point where they don't get any of the burning sensation, they don't get the regurgitation of food in the back of their throat or pain with swallowing, and their only manifestation is that hoarse voice, dry cough, laryngitis. In some people, if the reflux is particularly bad and it actually goes into the mouth without them realizing, it can destroy the teeth and they can get dental erosions. And so this is if reflux goes into the mouth, oral cavity, we'll call that cavity. So one of the problems with GERD is that over time, it can lead to inflammation of the esophagus, and it can actually start to erode some of the lining of the esophagus. Some of the major complications is inflammation of esophagus and breakdown of mucosal lining. So remember, the esophagus doesn't have that ability to produce protective mucus. This condition, when there's inflammation and breakdown of the esophageal lining, anytime you have inflammation in any part of the body, we use the suffix itis. So because it's in the esophagus, we often call it esophagitis. But there's a qualifying word in front of it. Because there is breakdown of the mucosal surface as well, we call it erosive esophagitis. Erosive esophagitis. If this gets into the deeper layers beyond the level of just the epithelium, it may heal, but when it does heal, it can heal with a scar. So you can actually get scar tissue in the esophagus. And one of the problems with scar tissue is that it contracts and it makes the opening smaller. It doesn't make for a very flexible tube that can take a bolus of food. And someone could get a scar tissue in the esophagus, and we call this a stricture, specifically an esophageal stricture. This is a ring of scar tissue. People may feel like food is getting stuck because it can't get through the opening of the esophagus, the lumen of the esophagus, because it's more narrowed. One of the biggest problems with gastroesophageal reflux disease is that over time, the chronic inflammation within the esophagus can lead to changes of the epithelial lining. And there will be a change in the stratified squamous epithelium, and it will change to simple columnar. It'll look very similar to the epithelium that you would find in the small intestine. This is an abnormal process. This is not normal at all. This should not happen. There's one cell type replaced by another cell type. And if you remember from our initial discussions early on in the course, we talked about cellular adaptations. And we discussed one cellular adaptation was one adult cell type turning into another adult cell type. This process is referred to as metaplasia. And in people who have long-standing gastroesophageal reflux disease that has not been treated, they tend to get a metaplastic change in the lining of their esophagus. And this metaplastic change is called Barrett esophagus. The problem with Barrett esophagus is that because there is a change in the type of cell, this means that there's some sort of a mutation in the in the cells of the esophagus that cause them to change to another cell type. And anytime that there's mutations, there are risk factors. It is a risk factor for cancer. And metaplastic changes are generally a risk factor for cancer. And that is true of Barrett esophagus. This is a risk factor for cancer. Most people with esophageal cancer will have an element of Barrett esophagus. So this is an important, the next 2 points are actually really important. Most people with esophageal cancer have Barrett esophagus. But this is the second important point. But many people with Barrett esophagus never develop esophageal cancer. And so what that means is that it is a risk. There's something about Barrett esophagus that causes some people to get esophageal cancer, but many people with it will just never go on to develop it. So we just say it's a risk factor. Risk factor for gastroesophageal, uh, a risk factor for esophageal cancer. People who have Barrett esophagus, they are monitored. They will get endoscopies. They'll get cameras down their throat to make sure that there's no changes in the Barrett esophagus. So when we think about diagnosing GERD, it is generally done on clinical history. We ask people what they're experiencing, when they're experiencing it. And sometimes we will try treatments for it. We'll try certain things to see if it makes it better. We also will often want to do an endoscopy to check to make sure that there are no serious changes within the lining of the esophagus or within the stomach. So we're going to do an endoscopy. So this is a camera that will go into esophagus, stomach. And that's to look for Barrett esophagus, cancer, and esophagitis. Once it's diagnosed, if there is any serious change, it will be monitored regularly to make sure that it's not developing into anything more serious. But we will generally try to treat it. And the way that we try to treat it is there's actually three major approaches. Management from an initial standpoint, and oftentimes a couple of these strategies are done at the same time. There are lifestyle modifications. And these things are relatively easy changes that can be made. So eating smaller meals more frequently reduces the amount of food in the stomach and reduces the risk that you're going to reflux. Not eating before bed. Raising the head of the bed to a greater angle so that you're not lying flat and then gravity can work with you. So raise head of bed. Oops, bed. Also avoiding any trigger foods. So essentially, if it tastes good, you probably shouldn't eat it because it can lead to reflux. Because obesity was part of a risk factor for developing GERD, losing weight can be helpful. And quit smoking. All of those things are really helpful in helping manage GERD. Then there's the pharmacotherapy, and this is where that whole idea of the cephalic phase of digestion becomes really important. Um, Pharmacotherapy, there's several things that we can do. Pharmacotherapy. We can directly neutralize the acid by using medications that we refer to as antacids. These are medications like Tums. Tums is really just calcium carbonate, CaCO3, and you chew them, you swallow them, they go into your stomach, and it acts to directly neutralize acid. For people who have occasional GERD, this usually works for them. Another one, which I actually I really love the mechanism of this. These are physical blockers. Um, Essentially, this type of medication, when taken, will foam up and it'll sit on the surface of what's in the stomach. And when the stomach churns, it'll actually stop the contents from going back into the esophagus. This medication is referred to as Gaviscon. If you look at the actual logo of Gaviscon, it's literally a person taking their hand and pushing the contents of their stomach down so that it doesn't burn their esophagus. It's fantastic marketing. So essentially what'll happen is that you'll have this, that's not quite right. There we go. Not quite right. There we go. Um, Essentially there'll be the stomach contents that will just like draw in like a fiery red that would burn the contents of the esophagus. If it went up there, it would burn. But when you take Gaviscon, they're either in tabs or it's a liquid that will foam up, and it'll make this sort of like foam that sits on the top of the stomach. And when the stomach tries to churn, this foam that would be sort of the Gaviscon, it stops this fiery red stuff from going into the esophagus and burning it. Gaviscon is great. I don't work for the company that makes Gaviscon, but it's a really helpful way to treat GERD. There are other medications to help reduce the acid within the stomach, and I'm just going to call them other meds to reduce acid concentration or proton concentration within the stomach. And we're going to actually go through a couple of them. And I'm going to bring you back to the cephalic phase of digestion and just some of the cells. So this is within the stomach, and I'm only going to talk about two different cells within the stomach. There are the enterochromaffin-like cells that, if you remember, produce histamine. And that histamine will stimulate the parietal cell to produce acid. That's essentially what is happening here. So if we actually look at what a parietal cell kind of looks like with the receptors that it has and proteins that exist within its cell membrane, I'm going to draw this parietal cell like this. This is a parietal cell. And on the surface of the parietal cell is a receptor for histamine. When that histamine binds to this receptor, it's going to stimulate the cell to produce hydrochloric acid. So from the enterochromaffin-like cell, this is histamine, and it's going to stimulate your parietal cell to produce acid. And the acid is produced by a pump that exists on the surface of the cell. It is an antiport pump, and it pumps hydrogen ions out into the lumen of the stomach, and it brings potassium ions in. But this histamine is going to stimulate this pump. We call it the H plus K plus ATPase. This is an H plus. Sometimes it's just called a proton pump. And we can actually target either the histamine side of things or the proton pump side of things. This particular receptor that exists on the surface of the parietal cell, it's not generally the same type of receptor. When you think of histamine, you think of allergies. Histamine that is going to lead to allergies, it is generally going to bind to a different type of histamine receptor, but it's still the same histamine. This particular type of histamine receptor is a histamine receptor, and it's a type 2 receptor. Type 2. And so this is called an H2 receptor. So what we can do is we can use a medication that can literally block the ability of histamine to actually bind. And this medication that can block the ability of histamine to bind, we would call a H2 blocker. These medications, you've probably seen a couple of them on the shelf if you've ever looked. Maybe you've never heard of them. I'll give you the trade names. One of them is called Pepcid AC. The other one is called Zantac. And for the generic name of these medications, they have a starting word and then they end with itidine. So Zantac is ranitidine. So example, ranitidine. That's how you can tell that it's an H2 blocker. The problem with H2 blockers is that there's still other ways that a parietal cell can be stimulated. It can be stimulated directly by the thought, sight, and smell of food. So the other place that we're going to use to reduce the acid is we actually block the pump itself. So if we block the pump itself, we call these proton pump inhibitors. Sometimes these are referred to as PPIs. And these block it literally blocks the proton pump. From a symptomatic standpoint, there's not really much of a difference between H2 blockers and proton pump inhibitors. One works directly on the proton pump, one works a bit indirectly on it. Either way, it reduces the amount of acid within the stomach. I better finish lumen. These medications you can identify because they start with part of a word and then they end with prazole. There's lots of them. Example, pantoprazole is one of them. Omeprazole, rabeprazole. There's tons. There's tons of them. Pantoprazole, the trade name of that one is Pantaloc. Pantaloc. And these medications usually work. The problem is that there are long-term side effects with proton pump inhibitors. They can lead to osteoporosis. They can lead to a B12 deficiency. Over long term, there seems to be an elevation in gastrin levels, which can be dangerous to the lining of the stomach. But it's a bit of a catch-22 because if you don't reduce the acid, there's a risk that the acid will burn your esophagus and it can lead to esophageal cancer. But then if you take these long-term, there are complications with it. It's all about a balanced risk-benefit analysis. We are at number 3. Yeah, number 4, if none of this works, there is a surgical option. There is a surgical option. And this surgical option is referred to option. It will surgically try to increase the tone around the lower esophageal sphincter. So if we actually look at our esophagus, We have this part of the stomach that actually extends a little bit higher than the where the esophagus joins onto. And then you have your stomach here. There you go. Okay, that's good enough. Here's your lower esophageal sphincter. If it doesn't have very good tone, what surgeons can do is they can take this part of the stomach. There's this little piece that extends above. This is called the fundus of the stomach. Oops, fundus of the stomach, and they can take this piece and wrap it around the esophagus to increase the tone. So they can wrap the fundus of the stomach around the area of the lower esophageal sphincter. This procedure is referred to as a fundoplication. So it's going to tack the fundus around the esophagus to just increase the tone. Fundus application. It secures it around the esophagus. Hopefully that gives you a little bit of an idea about a couple of diseases that can happen within the esophagus. But I really want you to pay special attention to the fact that it sort of went from this idea of, it went from GERD to Barrett's to cancer. And the idea here is that this long-term inflammation can eventually lead to metaplasia. And in some cases, we don't exactly know what will cause the metaplasia to transform, but in some cases, people will get cancer. I better put that in a different color. There we go. So it's that link of inflammation over a long period of time to a metaplastic change, and then that increases the risk of cancer. Hopefully that gives you a bit of an idea about at least a very common condition within the GI tract. I'll end there. And as always, if you have any questions about any of the material, please reach out and I'm happy to answer them. Hopefully you have a great rest of your day and we will connect soon. Bye, everyone.